Welcome to the Vision Series with Dr. Frank Brown Jr. as moderator. We will bring to the listening community different personalities in health and wellness, as well as professional and personal development to benefit our community through Dr. Brown and this program of the Vision Series. And so we say to you, welcome to this program, and we hope and pray that you enjoy it.
You're listening to Dr. Vision, brought to you by a grant from the American Academy of Communications. Their mission is to promote effective communication for better living. This is Frank Brown Jr., your host. Our program is intended to inform, educate, and inspire our listeners through hearing the lives, challenges, and victories of real doctors in our nation. As we explore these areas, we will use various lenses. Among them include personal, professional, and inspirational facets of life. Today, I have the pleasure of introducing Dr. Ralph Purcell. Dr. Purcell has had a very outstanding career. He was director of hand surgery at Columbia University in New York, where he also attended medical school. He's currently an orthopedic and hand surgeon in Scottsdale, Arizona. He's been practicing for about 11 years at that location. His career has spanned over 35 years. Dr. Purcell, on behalf of Praise 94.5 and Dr. Vision, welcome.
Thank you very much, Dr. Brown. It's a pleasure to talk to you and to be with your audience.
It's a pleasure for you to be with us as well, Dr. Purcell. We talked earlier, and you're from the Westchester area of New York, right?
I am. I spent the formative years of growing our family in Scarsdale, New York, a northern suburb of New York City.
Very nice, very nice. So you live in Arizona and have been an orthopedist for over 35 years. What are the biggest changes you've seen over that period in healthcare, both locally and nationally?
Well, there have been lots of changes, and some of them good and some of them not so good. We've seen a change in the whole financial structure in medical care, especially for the private practitioner. There are many more financial constraints, and that's affected the mindset of so many of the physicians, where they routinely feel as if they're running on a treadmill that's getting faster and faster, and their reimbursements are diminishing. And unfortunately, the end result is that many of my colleagues feel that they are forced to spend, or they choose to spend, much less time with their patients. So the patients are in and out in a blink, and so many patients feel that their doctors have sort of one foot in the door and one foot out the door. And that's problematic. Certainly the rise of computers has made a big change, and that's been helpful with the computerized medical record system, but it's also been abused by a lot of doctors. So many patients have an experience of their doctor having his or her back to them while they're typing on their computer the office note, rather than having that personal touch. So I think the patient-physician relationship has unfortunately eroded significantly with these factors. And then in my field, in orthopedics, we've seen some amazing things. We've seen engineering feats where we have super alloys for total joints. We have better microscopic techniques. We're understanding the biochemistry of disease and coming up with cures for cancers that were a death sentence years ago. So in lots of fields, in lots of directions, there have been dramatic changes over the course of my career.
Excellent. Tell me this, Dr. Purcell, what are you talked about alloys for joints and things. Can you give us a sense for the, if you will, lifespan of various prosthetic joints? What's the lifespan of a knee or a hip replacement?
Well, that's a great question, because over the course of even my career, we've seen a multiplier effect in the lifespan of these joints. When I started my practice in 1986, knee replacements we're lucky to last 10 years, maybe a little bit more than that. And that would mean that a lot of people were destined to have revision after revision of their knee replacements. And now the standard is 20, 25 years with the appropriate technique. We've learned better techniques on how to apply total joints in patients, and we have better structural materials that don't wear out as quickly. And we've also learned how to be what we call modular, so that if one part of the total joint is worn out or stops working, we can typically replace that part and not replace the entire total joint. And of course, that makes for a much happier patient and a patient who can do more over a longer period of time with each total joint. Different parts of the body respond differently. We always found that hip replacements lasted longer than knee replacements in the past, but now they're both doing very well. Some of the ankle joints, the artificial ankle joints or artificial wrist joints, are still in their relative infancy, and they don't last as long. We're having more problems with them, and I think the surgeons need to think twice or even three times before they consider placing that type of joint in people. There has to be a good indication for doing this particular surgery. But we found that they're much better than they ever were, and I strongly suspect it's only going to get better and better over time.
Excellent. Thank you so much for that comprehensive response. So I want to share with you a brief vignette and get your position on the statement that was made. Orthopedic colleague and I were having dinner a few years ago, and my sister-in-law was about to undergo bilateral knee replacement. And so I shared with him that situation, and this was his response, that in his opinion, there was a lot of unnecessary knee replacement surgery, and since prospectively you can't really tell who, quote, needs a knee and who doesn't, you only know retrospectively when you make rounds that day after and the patient responds. The person who needs it says, "Doctor, my hip is much better." The person who didn't need it is the person who's complaining about the pain and all. Give me your perspective on that.
Well, I don't quite agree with that.
Okay.
I think that as surgeons, we need to think prospectively. You don't want to decide whether or not an operation has been appropriate and beneficial based upon just the response of the patient afterwards, because the patient might require a knee replacement and the results can be disastrous. I can give you the personal example. My mother was my father's caregiver for his final years, and once he passed away, and it was she took the opportunity to have her arthritic knees replaced, and she absolutely needed them. She was suffering greatly, and she had the surgery. It was appropriate, and there was a major complication with the surgery that changed her lifestyle for the worse, and yet the surgery was appropriate. So I think there are very strong ways of determining the indications or the appropriateness for an operation. You want surgery to be the last treatment, not the first treatment. You don't want to be frivolous in offering surgery, and you want the patients to understand that there are significant risks, significant complications, but then on the other side, significant benefits if they're the right patient. So much of it is choosing the appropriate candidate and educating the patient as to whether or not that person is the appropriate candidate. And if not, what are the alternatives? Has that person done everything non-operatively or what we call conservatively that can be done to improve the quality of life? And if that can't be done, then surgical intervention is the appropriate step. So we are proactive. We don't want to be retrospective about this. We want to be proactive.
Excellent. For the listening audience, Dr. Purcell and I are discussing information for your educational benefit. We are not practicing medicine. Should you have any problems with your joints, don't hesitate to call your physician or the health department to get guidance. Again, we are not practicing medicine, just sharing information. Thank you so much for that overview, Dr. Purcell. And you're right, that is a different perspective. Give us a sense for what are some of the parameters that let you know for sure someone needs it. Conservative measures have failed. What else lets you know this person really needs knee replacement surgery?
Well, there's several things that you have to take into account. You talked about conservative measures, so there are tiers of that treatment. There are non-invasive treatments that don't require penetrating the body, like anti-inflammatory medicines, lifestyle changes. Maybe the person with their belly hanging over their belt buckle needs to lose some weight and can miraculously find that the knee doesn't hurt as much. Or maybe their activity changes. Maybe someone who likes playing singles tennis needs to play doubles tennis, or maybe avoid that sport and think of another sport that's not as troublesome for the knee, like swimming or bicycle riding. So sometimes lifestyle changes, maybe even changing the occupation that a person does, physical therapy, bracing, and then injections, steroid injections. We could spend the entire radio show talking about the various injections that people are getting, and unfortunately the lack of validity of some of those, like platelet-rich plasma, PRP, that the public hears about, or stem cells that are touted as the miracle cure, that we believe have a place in certain aspects of orthopedics, but not necessarily in rejuvenating joints. And unfortunately, people have come up with great advertising names, rejuvenative medicine, without the scientific basis behind it. And then we also have to make sure that the patient can follow instructions. If a patient can't follow instructions, then that person is apt to destroy their newfound joint. And also you want to understand the psychiatry and the psychology of why someone is getting a total joint. Is their quality of life so destroyed? Is it so limited that they need something to get back into the interacting with the human race? Or do they want to run faster or do the double diamond slopes while skiing, and they don't feel they can do that? One just can't be frivolous with considering a total joint, because it comes with a responsibility on the part of not just the doctor, but the patient, to treat that well so that it has its appropriate lifespan.